This is Case Study 3, titled Liver and Pulmonary Diseases Complicated by Cellulitis, Pseudomonas, Clostridium difficile, Sepsis, and Respiratory Failure. Our learner objectives. By the end of this presentation, you will be able to, 1, distinguish by defining characteristics the cellular differences between cellulitis, Pseudomonas, Clostridium difficile, and sepsis bacterial infections. Should be able to name 3 signs and symptoms each of cirrhosis, hepatitis C, and chronic obstructive pulmonary disease, or COPD. Correctly identify 3 contributing factors toward the development of liver cirrhosis, and identify 3 areas where increasing patient education could aid in the prevention of both pulmonary or liver diseases. Just to give a quick overview of the patient, there are a lot of changes that happened pretty rapidly in the progression of her hospital stay. So I just wanted to give a quick overview so that makes more sense and you can follow the progression of it. So upon admission, the patient had complications related to a lower leg wound, which involved some cellulitis. And this cellulitis is closely coupled with her existing hepatitis C and liver damage, which was idiopathic in nature, which we'll get further into later. But as her case progressed, her prognosis diminished pretty rapidly within the first couple of days. She had a severe loss of appetite. She refused multiple meals. Her Pseudomonas bacteria was found within her wound bed upon culture testing, and then that bacteria spread to her blood from the wound itself to infiltrate the rest of her entire body, and sepsis was defined at that point. She received a variety of antibacterial medications, and from that use, she developed severe diarrhea, nausea, cramping, from the development of C. diff, which was present within her GI tract. Coupled with her existing end-stage COPD, she developed respiratory failure and had to be mechanically ventilated, and at that point received enteral nutrition support for her sole source of nutrition at that point, after having not eaten for so long. And then upon discharge, the patient was transferred to a skilled long-term care facility where her care could be continued with her prognosis poor but unknown. So just to start off, the disease process with cellulitis in particular. Cellulitis is it is a gram-negative bacterial infection of the skin. So it goes beyond just a rash of the skin. To the right there is the photo. It's sort of small little dots of redness. There could have been a wound there in the center of that photo at one time. Oftentimes cellulitis does surround a wound bed itself. But there are also the edges around the cellulitis itself can often be outlined with a pen or a marker. It has pretty defined edges on it, and it can go from being somewhat spotty and red like that to just almost a complete solid red mass surrounding a certain area. And because of the increased pressure within your lower limbs versus your upper limbs, cellulitis, the development is much more common within the lower limbs, feet, legs, ankles, that sort of thing, versus arms, although it does occur in the upper limbs as well. And this is really common with decreased liver function. And the reasoning for this, it is a bacterial infection, and our liver does process toxins from our blood. And the bacterial toxins begin to increase within the body and show up in the form of a bacterial infection that manifests within the skin. It's also common with various vascular diseases. So when there's no blood flow to a certain area and there's some cellular death, the bacteria can infiltrate in those areas as well. Also with various surgical procedures, traumas, so maybe a motor vehicle accident, something like that, where there's been some significant tissue damage, is also an area of the skin which is prone to bacterial infection, and cellulitis is common within those. Also in pregnancy, with the increase in the pressure in the lower limbs and swelling, obesity for the same reason, alcoholism with a lack of liver function as well as a contributing factor, and then with diabetes as well. So various signs and symptoms of cellulitis. We looked at the photo there, but as far as a sensation, there's a tingling or numbness of the skin, and this is caused from the lack of blood flow to that area of the skin. Redness to the skin, but this can also include some blistering as well. Again, it can be surrounding a wound itself that could be very severe. Also, the patient may have fevers, chills, shakes. The bacterial infiltration induces cell death within the tissues surrounding that area. And in very rare cases, sepsis can result. And sepsis is unique in that it does not stay contained within that generalized area like sepsis, like cellulitis does. Sepsis infiltrates the blood, and anywhere that blood circulates, sepsis can also circulate. So it affects all parts of the body receiving blood. In the diagnosis of cellulitis, a culture sample is usually obtained and tested for gram-negative bacterial growth. But it also can, taking that culture sample as well, some feel can spread, increase the spread of the bacteria from that actual region to other regions of the body. So there are cautions maybe not to culture the area and to visually just educate practitioners on identifying cellulitis properly versus culturing. So there is kind of a controversy, and so within your facility there may be cultures, there may not be. It may just be an identification through visual inspection alone. With cellulitis, again, it is coupled with, when coupled with hepatic insufficiencies, there's a 6.7% chance that a person will develop cellulitis. And then following cellulitis, once they've had it, there's a 95% chance that it will reoccur at some point. So it's very important as a practitioner to pay very close attention to assessment as far as physical of the lower limbs and feet, ankles, those regions for the presence of cellulitis, and to be proactive in trying to prevent some of the contributing factors that towards the development of cellulitis. So, reducing weight and decreasing some of that pressure and edema in the lower limbs. Also, reduction in alcohol consumption and various other liver disease contributing lifestyle factors. In the treatment of cellulitis, antibacterial antibiotic use is the only way thus far to treat it, and the average time, it's quite long, is 114 days, which is pretty significant for antibiotic use. There is some controversy as to this long-term antibiotic use. Some say that it is harmful because treating for that long a gram-negative bacterium can contribute to bacterial resistance of the drug itself, so in the future it may not work. But then there have also been studies that showed that there's been a 35% reduction in the reoccurrence, which we said was a 95% chance once it's happened once. So there is some promise with antibiotic treatment. So it's a little bit controversial, but more likely than not, you will see antibiotic use pretty much solely for the treatment of cellulitis. So Pseudomonas is another gram-negative bacteria. it is closely related, similar to cellulitis, and that infects the soft tissues of the skin most commonly. And it is typically found within the wound beds of patients who have cellulitis. So it's very common in hospitalized and long-term care patients who have weakened immune systems. So the elderly, someone who's been through some sort of cancer treatment, an HIV positive patient, any of those patients who have weakened immune systems in order to fight off bacterial infections, Pseudomonas is much more likely to result. But this, unlike sepsis, which can travel, like sepsis, which can travel, Pseudomonas can also travel. So it can travel throughout the blood and end up eventually with a resultant sepsis diagnosis. For the treatment, again, solely targeted gram-negative antibiotic use is the only way to cure a Pseudomonas infection once it's identified. Sepsis is similar. Again, they both do travel throughout the blood, throughout the body. And sepsis is unique in that it is an immune system reaction arising from widespread infection. So it is circulated to all regions of the body, again, where all blood flows, which would be into every capillary of the body. And again, it contributes largely to hospitalized and long-term care mortality death rates and sickness within those facilities. And it is rarely complicated in association with cirrhosis. So the reduced liver function, though, is a contributing factor to the development of sepsis because, again, the body cannot filter out the toxins that have infiltrated the blood. And again, treatment is through the use of antibacterial medications. Clostridium difficile, also called C. diff, is a little bit different in that C. diff is a bacterial infection that is found within the gastrointestinal tract. And this induces symptoms including diarrhea, fever, nausea, loss of appetite, or abdominal pain. And again, as with the other bacterial infections, it's very common among long-term care and acute care setting patients. And this is largely due to the use of prolonged antibiotic use. And again, when you're using antibiotics to treat one of these bacteriums that have occurred, the time frame in which they'll have to be used is quite extensive. And so the likelihood of development of C. diff increases with every new day, basically, that the patient is on the antibiotic. In diagnosing C. diff, stool samples are either taken or a culture sample via, if it were something obtained from some sort of scope, or you could get an actual culture tissue sample from the GI tract, and that can be tested, but that's not nearly as common as testing the stool. So more often than not, in hospital long-term care settings, the stool will be sampled in order to positively diagnose the existence of C. diff bacterium. And then again, the treatment is oral antibiotic use targeted specifically towards C. diff. So there are some specific medications that do target C. diff alone versus some generalized, gram-negative or gram-positive antibiotics that can target larger groups of bacterium. There are some specific types just for C. diff, which seem to be promising. With hepatitis C, this is caused specifically from exposure to the hepatitis C virus. And so this can be contacted through a variety of different ways, but it must be through direct contact with infected blood, so someone who has the infection already. Generally, this is most commonly traced back to needle sharing among individuals who are drug users. But there have been cases where past surgical procedures or blood transfusions, those prior to 1992, when there were not specific testings done to ensure that the blood was free of the hepatitis B or C viruses, could be contributing to factors to the development or to the exposure to the virus itself. Any sort of, I guess, tainted puncturing of the skin. So if someone were to have some sort of trauma where they were punctured with something that had previously punctured an infected person, there have been very rare cases, but still occurring, where college roommates, for example, shared a razor in college in the shower, and one was infected not knowing it, the other became infected and went years without any signs or symptoms, but were able to trace it back to that use, having been diagnosed at that point. There are also cases where a patient, it's just idiopathic in nature, where there had to have been some sort of infiltration, some sort of direct contact, but the patient just may not know, where or how that happened. So in the case that we'll see here today, the patients had some past surgeries, but largely it was idiopathic in nature, just did not quite know where it came from. Various signs and symptoms of hepatitis C: increased fatigue, loss of appetite, and just from the inflammation occurring within the liver, there can be some generalized abdominal discomfort. And decreased hepatic function. One of the more common signs and symptoms of that include reddened palms, some ascites within the abdominal region, and then hepatic encephalopathy, which causes some mental clarity issues. In the diagnosis of hepatitis C, a blood test will be performed, or a liver biopsy can also be obtained. There exists largely a very strong concern anytime that the liver is punctured for intense bleeding to occur. And so anytime that a liver biopsy is done, there just has to be increased awareness and care given there for the sensitivity that a bleed could occur, and just making sure that the risks of obtaining that biopsy outweigh, the benefits. The benefits outweigh the risks. Liver damage, though, a lot of times is the very first sign, because again, people can go for years asymptomatic and have no idea that they have come into contact with the hep C virus. But liver labs, bilirubin, alkaline phosphatase labs will be checked for proper liver functioning. And then at least 20 to 30% of patients with the hepatitis C virus do eventually develop some sort of cirrhosis of the liver, or the hardening of the liver that renders it really incapable of functioning properly. But in the treatment of it, some various antiviral medications are typically used first to help with the ailments, the chronic inflammation of it that's occurring at the time. But then there has been some new research, which is promising, showing that they can go in there and alter the genes, rendering the antigen incapable of replicating. Therefore, they're altering the DNA of the hep C virus itself, and so it's unable to continue to reproduce, thus curing the patient. So once the flare-up or the acute stage of it is taken care of, they can then stop it from going any further, eventually curing them. So, but that's not as widely seen yet. It's kind of a new thing. So with cirrhosis, we said 20 to 30% of patients with hepatitis C will eventually develop cirrhosis of the liver. And what this is the replacement of healthy liver cells with hardened scar tissue cells. So they're unable to, the cells of the tissue itself are unable to develop and perform all of the functions that they once did. What it happens actually, it's these nodules begin to develop around fibrotic tissues that have been hardened as well, which renders them completely non-functional and cuts off that area. So normal blood flow through the liver itself and the production of or the flow of bile through there as well is decreased because of an entire region where they once flowed and now they cannot because it's completely hardened with no veins or vessels to go through. So this increases the hepatic pressure both within the existing veins and vessels within the liver. So the pressure builds up within the liver to every vein and vessel that's left, but then it also increases portal pressure, and that in turn increases pressure in various other parts of the body. So within the esophagus, with all along the GI tract, within the tubules of the kidney, and then within the abdominal cavity itself. So anywhere that pressure builds up, there exists the increased risks for sporadic bleeding within those areas because the body still has to process the same amount of blood through the body and through all of these various areas, but with increased pressure and flow behind it now. So the liver's functioning is greatly diminished, and toxins also begin to build up because it is rendered non-functional anymore. Various signs and symptoms of cirrhosis include increased weakness, fatigue, nausea, vomiting, lack of appetite, and weight loss. The patient may experience itching throughout their body, some ascites, edema in various parts. Anemia is very common with a cirrhotic liver. Again, we had talked about the redness of the palms and then yellowing of the skin, also known as jaundice. The increase in the pressure, the portal hypertension, again, we had said contributes to sporadic bleeds. So if that were to be within the GI tract, for example, you would see bloody emesis or stool. Or if it were to be, if that increased pressure were to affect the kidneys, then you would have blood in the urine. So the esophagus as well, along the GI tract, they might cough up blood or with the bloody emesis as well. That might be a contributing factor to that. There's also ammonia will begin to increase from the breakdown of the protein within the diet, and this cannot be filtered by the liver any longer when it is not functioning the same way. And this buildup of ammonia leads to hepatic encephalopathy, and that is contributes largely to mental confusion and a confused state, and that can be deadly. And but that is one of the signs that something liver-related, possibly severe cirrhosis, has occurred when patients are very confused. Also, on the surface of the skin, spider-like veins and vessels will begin to be seen as well. So cirrhosis, some of the common origins, alcohol intake, primarily excessive. Once the liver has just taken a load for so long, the liver begins to be damaged and cannot filter that same amount of alcohol anymore. That is perhaps the largest contributing factor to the development of cirrhosis, but also, as we had mentioned, chronic hepatitis B or C viruses also can lead to cirrhosis. There's also non-alcoholic steatohepatitis, which causes some inflammation and some fatty deposits within the liver, leading to damage. So this has nothing to do with alcohol intake, although on the surface it may seem as though it does, but there is a non-alcoholic sort of version which mimics the sort of reaction that occurs with excessive alcohol intake as well. Also, Wilson's disease, hematochromatosis, and cystic fibrosis are possible origins for liver damage and eventual cirrhosis. The prevalence of cirrhosis is more common among men. However, when a woman drinks alcohol in excess, she is just as likely to develop cirrhosis as a man. But in general, men are, it is prevalent more among men, also with obesity. And a lot of prolonged prescription drug use, so acetaminophen or NSAIDs like Tylenol, whose target really is the liver, and who the drugs are metabolized within the liver, and so they put an additional strain upon the liver. So continued use of those, prolonged use of those, can contribute to liver damage and eventual cirrhosis. So in the diagnosis of cirrhosis, the physician may feel the abdominal region. The liver often will shrink in the very first stages of liver cirrhosis because you're taking kind of a larger mass of cells, and when you shrink it, kind of like you shrink a balloon, it sort of decreases in size, but eventually it will, with the progression of the disease, the liver does enlarge, and it can be quite significant. So they'll do a physical assessment, and then again with some of the other signs and symptoms, the reddened palms or, ascites edema, that those sort of physical manifestations of cirrhosis they'll look for as well. Also, they'll look at various liver function tests and then labs that indicate liver functioning. Hepatitis B and C virus testing, since it is a large contributor to the development of cirrhosis, will be tested. Those antigens will be tested for. An abdominal ultrasound or MRI may be developed, but then again, a liver biopsy may also be done. As we talked about, with there is that elevated risk of bleeding with the liver, but it, as long as the benefits of knowing and diagnosing it can be more beneficial for the patient, then that will be looked at as a part of the diagnosis process. To the right there is just a visual of the GI tract below and the liver sitting above it. You can see the nodules surrounding the fibrotic areas that are hardened on it. The prognosis for someone with cirrhosis largely depends on the complications that surround it. So, and once damaged, liver tissues cannot be repaired, so it is, a transplant may be a likely route for helping a patient there, but just managing some of the complications that surround it and that comes along with liver damage is really the best sort of treatment for someone who may not be an eligible candidate for transplant, or who is in such advanced stages that doing a transplant may harm them more than help them. In the treatment, prescription drugs, again, whose target is not the liver, so you're reducing that demands placed upon the liver. And then with hepatic encephalopathy, for example, if your ammonia level gets too high, lactulose is one of those prescription drugs that does eliminate the ammonia via the way via stool excretion from the body. It does take a little bit longer because that is the route that it takes, but that is one prescription drug that's used for some various complications we were talking about, or liver transplant again. The medical nutrition therapy for someone with cirrhosis typically is a sodium restricted or reduced sodium diet. May not be fully restricted. 2 gram is generally a pretty moderate reduction. 1 gram would be considered more of a sodium restricted diet, or just a much more severe restriction there. A fluid restriction may be put on the patient to reduce complications with edema and some ascites that may build up. There is some research showing as well that as much as 90% of a benefit has been seen when patients use a sodium or fluid restricted diet coupled with diuretic use. So that is one promising method for reducing some of that edema and ascites and fluid buildup that occurs. Also, a decrease in protein, and this has to do with various stages, how bad it is. Decreasing protein generally to 1.0 to 1.2 grams per kilogram of body weight. When someone were to have hepatic encephalopathy and the elevated ammonia level was present, you don't want to increase protein more and produce more ammonia. So the reduction there exists, and I guess it's a clinical judgment, but between 0.6 and 1.2 grams per kilogram if ammonia is an issue. Supplemental fat-soluble vitamins, so A, D, E, and K, which are processed within the liver, are rendered unable to be processed with liver damage. So supplementing with those can be very beneficial. And then also the supplemental 25-hydroxyvitamin D, which is the biologically active form of vitamin D, has also been supplemented and shown some promise because vitamin D deficiency is very prevalent among patients with cirrhosis of the liver, because that biologically active form is actually hydroxylated within the liver. So if that cannot occur, then it cannot be absorbed by the rest of the body. So putting it in there in that biologically active form helps to eliminate the step required of the liver at that point and make it more bioavailable for use by the body, and increasing vitamin D stores. So with COPD, chronic obstructive pulmonary disease, it currently stands as the 4th leading cause of death within the United States, so quite prevalent. COPD is characterized by increasing irreversible airway constriction and basic lung function. It is often coupled with emphysema and chronic bronchitis. They kind of go hand in hand with a COPD diagnosis. With emphysema is similar to bronchitis, but slightly different. Emphysema is the obstruction of the airways, so the actual constricting of the airways, where bronchitis is the increase in inflammation. So it may, with bronchitis, increase coughing, sometimes the phlegm that can get in the way. So they are slightly different. Excuse me. Also, with someone with COPD, they have, it takes an increased energy expenditure for them to breathe. So following a meal as well, the patient may have increased pressure within their abdominal cavity because where the stomach is located after having eaten, and this increased pressure is very uncomfortable for someone with COPD, because then it places an increased amount of pressure upon the lungs themselves. And so anorexia and malnutrition are very common because patients often, because it's so uncomfortable following eating a meal, they often convince themselves that they are not hungry even when they are. And so getting them to eat is sometimes very difficult. It's sometimes a mental game whether or not they are truly not hungry, or whether or not they're just avoiding that very uncomfortable, very hard to breathe feeling. So again, up to 50% of patients with COPD in acute care settings have COPD, and then 22% within the general population have anorexia or malnutrition in some form or way. And because of the increased energy expenditure that it takes to breathe, they have difficulty maintaining their weight as well. So eating less, loss of appetite, and then they are burning it quicker, the calories that they consume, because they are putting out more effort just to breathe over a normal person. So risk factors for the development of COPD: cigarette smoking is prevalent in 90% of cases, so it is the #1 risk factor. Also, various environmental exposure to toxins. So if someone were to work in an old building that had asbestos in it, or had a spouse or a sibling that smoked and they inhaled secondhand smoke. So a lot of this can be workplace related for a lot of people, or just exposure within a home. Living in more of a city versus a rural area, also where there are just more environmental toxins within the air, can contribute to the development of COPD. Also, a history of childhood infections, but where in some form or another the lungs have been damaged, are contributing factors, and increased age as well. With COPD, various exposure to pollutants, again, increase the inflammation that exists within the lungs. And then with chronic bronchitis, there's a decrease in cilia function. So the air is not able to get in there because they're often damaged or flat-lying, and they obstruct the airways. There's also increased phagocytosis and decreased immunoglobulin A, so IgA, to respond to lung damage. So recovery from that is difficult. Increased mucus buildup and possible fluid within the lungs, which contributes largely to bacterial infiltration within those areas. Again, damaged or flat-lying cilia, and then narrowed airways as a part of the emphysema part of COPD, which is commonly coupled with emphysema. There's a high prevalence of COPD in liver disease. 13.8% of individuals with COPD have some sort of liver disease as well. There are similarities between various lifestyle choices of people that develop both cigarette smoking and drug use coupled together, maybe increased alcohol consumption coupled together, kind of may be a contributing factor for the development of both. So it's, as a practitioner, it would be important to note, the need for preventative measures like quitting smoking, or preventing malnutrition even, or reduction in alcohol intake for someone who has COPD, just because of their increased risk for eventual liver disease damage. And with the coexistence of both, chronic hepatitis C is inflammation inducing, and increases the inflammation within the lungs. And then the increased also increases the chances of COPD exacerbation. So they do exist together, and the hepatitis C is often very damaging and inducing COPD flare-ups in patients with both hep C and COPD. So this is the patient profile for Mrs. D. She is a 58-year-old female. She is 5'4", 64 inches tall. She weighs 247 pounds, which is 112.3 kilograms. Her ideal body weight for a woman that is 5'4" is 120 pounds, but her usual body weight ranges between 200 and 300 pounds. She stated that it fluctuated widely between, that 100 pound mark because of the presence of edema, some different lifestyle choices, her dietary intake, that kind of thing, but that she was always a big up and down kind of person with her weight throughout her whole life. Her BMI currently was a class 3 obesity BMI 42.4. And the patient was full code status, so she did agree to wanting mechanical ventilation or artificial nutrition infusion supplied if necessary during her stay. The patient is married, lives at home. With her obesity, struggled largely with self-care. She was very dependent upon her husband to complete various activities of daily living. She was disabled. Within the previous 2 years, she'd become a Medicaid recipient because of her disabled status. She used a walker and a wheelchair. Mrs. D did not maintain a long-term career of any sort. She stated maintaining various odd jobs. She cleaned homes for a period of time, babysat. She does have 2 grown children and then 2 grandchildren with her husband, and she is of the Methodist faith. Surrounding Mrs. D's admission to the hospital, she presented to her general practitioner, her physician's office. She had been on some outpatient drug therapy for the treatment of her lower leg wound that involved the cellulitis in her leg. And the outpatient therapy failed, and the wound did not progress to heal. And so after visual assessment of the wound itself, the physician then admitted her within the hospital. Mrs. D's family medical history is quite significant given her current medical conditions. Her mother had a heart attack at age 67. She stated that she died shortly after, within a couple of months. Her father was diagnosed with COPD. He was a longtime smoker and died in late adulthood. Not sure exactly at what age. Her brother also currently has a COPD diagnosis as well, but he was diagnosed in his late 50s, so not too long ago. And again, the same past smoking history. Mrs. D herself does have a pretty extensive history of smoking. She smoked approximately 1 pack a day of cigarettes for 35 years. And then 2 months prior to admission, she was diagnosed with end-stage COPD. So she had known that she'd had COPD for a while, but end-stage COPD. And with end-stage COPD, there are 4 stages, 1, 2, 3, and 4, progressively worsening. With stage 4, you have a less than a 30% oxygen capacity of your FEV1, which is a lung function test, which tests the forced expiratory volume within 1 second. So less than 30% oxygen capacity within for that FEV1 testing. She had worsening liver function within the previous 5 years, so some various anemia, cellulitis, and edema. She was diagnosed with chronic hepatitis C, but as mentioned earlier, this was idiopathic in nature. She did not know where exactly this came from. There was no prior drug use, no needle sharing, which is common for a point of access for getting hepatitis C, contracting it, but she did have some past surgical procedures. These included a C-section with the birth of her son. She had had a tonsillectomy at the age of 6, and then hernia repair approximately 12 years ago. So there exists in her mind a possibility that these were contributing, factors, or not factors, but points at which she could have contracted hepatitis C, but again, could not pinpoint exactly where it was. So it was considered idiopathic in nature. She also had a history of anxiety and depression, and then female stress incontinence, which she related to periods of, when her anxiety and depression were very high, she could not urinate. But, with medication use and stress relieving techniques and whatnot, she was able to get that under control and have no long-term issues with that. She had been hospitalized multiple times within the previous year for various issues with cellulitis, wounds, edema, that sort of thing. So as far as the patient's disease progression when she was in the hospital, again, she went to her general practitioner. She was admitted after her cellulitis. The cellulitis surrounding her wound did not get better over the 2 weeks that she was receiving the antibiotic. So she was admitted into the hospital and into the general 7th floor area of the hospital. She had mild wheezing. Her oxygen saturation was at 90%. Zazen was prescribed as an antibiotic to help treat the cellulitis within the wound. She was also prescribed a cardiac 2-gram sodium diet by the doctor, so a combination diet there. Her Braden score was pretty good, a 20 out of 23, but she did have that existing wound, and so the wound nurse was referred at that point. Following the next day, the Pseudomonas was cultured from the wound bed and confirmed for the gram-negative bacterium. Improvement was seen in her wound. There was no presence of sepsis. The doctor was very optimistic in progress notes that she would return home within 2 days. She did have some labored breathing that continued, but she was using a nasal cannula during the daytime and a BiPAP at night. Her meal consumption remained at 100% for the first 3 days that she was there, so she was eating great. But as the next couple of days went by, she had increasing fatigue and weakness, persistent diarrhea. The C. diff at that point was cultured and confirmed. They cultured it after seeing the persistent diarrhea occur. The Zazen antibiotic was discontinued at that point and replaced with vancomycin to try something different, and that would be more specifically targeted towards the C. diff bacteria. Her neurological score at that point was 15 out of 15, so she was very cognitively aware. As the day went by, though, fever and tachycardia developed. The doctor added Flagyl to the Zazen as another line of bacterial antibiotic use. Her level of consciousness started to decrease, and eventually she was transferred to the PCU. At this point, for 6 meals, she had refused, with a couple of meals there, making her meal consumption 22% at that point. So she had gone from 100 to 22%. She was very undernourished at that point. Things had started to get more serious at that point, and her disease started to progress. She did remain in the PCU for 4 days after that, still on her cardiac 2-gram sodium diet at that point. Tachycardia did improve, and she was transferred back to the 7th floor. She continued her meal refusals, so that area did not improve any better. The dietitian, was referred at that point, and we went in to see the patient. With the continued downturn within her health coupled with malnutrition and getting no form of PO intake, it was decided that she would get a Dopphoff nasogastric tube inserted. And she started to have increased edema in her legs, her arms, and her abdomen. She started to become mentally confused, so the suspicion there for encephalopathy began to be a concern. Her white blood cells were elevated, and at that point they cultured and sepsis was confirmed. And then they reduced her IV fluids to make sure that she was not on overload from fluid intake at that point. The patient's visual responses eventually just completely diminished. Her neurological score went from a 15 out of 15 to an 8 out of 15. She was transferred from the 7th floor back to the ICU this time, the intensive care unit. The patient went into complete respiratory failure and had to be mechanically ventilated. She had 4+ generalized weeping edema at that point. Her Braden score had dropped drastically to 12 out of 23, and her wound was degrading completely. She was placed on an enteral nutrition formula, Oxepa, to increase her availability of oxygen and help her to breathe on her own, with a very slow progression to her goal rate at that point to prevent overfeeding. Within the following 2 days, she was extubated from the ventilator, and her cognition returned. Her edema had gone from a 4+ generalized weeping to 2+ generalized, and then she was put back on the enteral nutrition formula at that time. And since she had reached her goal rate in the ICU with the Oxepa, her goal rate was maintained with the Ensure almost instantaneously and maintained at that point. So, and then she was, on day 14 of her stay, she was transferred to a skilled long-term care facility to continue her care. So for the nutrition care process, the assessment, food nutrition related history. Mrs. D's husband completed all of her grocery shopping and cooking. He was a big contributor to helping with her activities of daily living. Mrs. D's home diet was a regular diet, which she stated she had no restrictions. She denied any recent weight loss or anorexia. She struggled, she said, with portion sizes. That was an issue for her. And then she also admitted to being an emotional eater. And then we went through just a usual food intake. She said for sandwich, she usually had, for lunch, she usually had a sandwich with some sort of, deli meat and cheese, which she didn't consume regular sodas. And then with dinner, Southern comfort foods were her favorite. Her husband often cooked for her these types of meals. So she said it always had some sort of meat, gravy, potatoes, some other sort of comforting vegetable. And then for dessert, she almost always had ice cream, but not just for dessert, but also for snacks as well. The patient during her stay had a variety of medications used. So the first is Zofran, which was an anti-nausea, and she did have some nausea. It's at various points throughout her stay. Colace, which is a stool softener and laxative. She also was put on Lomotil during the period where she was, the C. diff was confirmed and she had persistent diarrhea. Norco was prescribed with pain reduction, and then also Tylenol PRN as needed. Norco, I have in there twice, I'm sorry about that. Aldactone was a diuretic that was used, and so to help with her increased blood pressure and to reduce some of the inflammation and the edema that she had, which was 4+ at various points. Lovenox, which was an anticoagulant, so to ensure that her blood was not clotting, leading to various blockages and other complications and bleeds. She also was put on Duanib, which is a bronchodilator, so she had used some albuterol with her BiPAP on her nasal cannula, and then also another bronchodilator as well. The Zazen was used to treat the gram-negative bacteria, originally the Pseudomonas, and then vancomycin with the Pseudomonas as well. The Flagyl was prescribed when they found out that she had the C. diff. And then for just IV hydration, she was given half normal saline for a period of time and then normal saline. Xanax for her anxiety, periods of anxiety, just to help calm her, and then Ambien for sleep. Upon admission, the patient's present nutritional status was very poor. She had made very poor nutritional choices, which were reflected in her home diet and the choices that she made. She was extremely obese, reflective from her elevated BMI, class 3 obesity BMI. She had various exacerbated disease states, so the chronic Hep C, the COPD exacerbation, and then the various flare-ups with, bacterial infections and the degradation of her wound. She was extremely edematous, just completely overloaded with fluid at various points, very, very full of edema. Throughout her arms, legs, it was nearly everywhere and very visible. She also, throughout her stay, refused a wide variety of meals. There were lots and lots of meals, loss of appetite, malnutrition was pretty prevalent at the point in her stay when we saw her, and then continued until she was basically extubated and maintaining enteral nutrition status at her goal rate. So this is the biochemical data for the patient. These are the abnormal laboratory values obtained on day 12, and this was during the time period when the patient was intubated. So at kind of the peak of her disease progression. We can tell that her creatinine level was low. This was reflective of her decreased muscle mass that could be likely from her malnourished state. Also, a bacterial infection existing within her kidneys could have contributed to the low creatinine level. Her BU and creatinine ratio, also after being fed, the patient had been receiving increased protein within her diet, which could be reflective from that. It also with the sepsis, acute kidney failure is very common, and with increased stress, so it is likely that that increased stress could have contributed to some renal functioning or malfunctioning at that point in her stay. The carbon dioxide was high, which is extremely common with worsening lung function and with her COPD condition. Her total protein was low, which is indicative of just the progression of further liver damage, but then also just acute hepatic infections. Her albumin level was low, which we use as just a predictor of mortality and morbidity. Mrs. D was certainly very sick at this point in her stay, so worsening health status, and then also decreasing liver function, because albumin is synthesized within the liver, and with low liver function, her albumin level would be low. Her white blood cell count was very high. This is likely indicative of the various inflammatory responses happening in the body as a result of the widespread bacterial infections, and then also with increased cell death, white blood cell counts can be increased. Her red blood cell count was low, indicative of her low oxygen capacity with COPD, and then she was anemic, so low iron stores, and then hemoglobin for the same reasons. Also, in some laboratory tests that were conducted, the ISTAT blood test was obtained, and this, her low levels of the PO2 and PCO2 are indicative just of her reduced lung function and COPD and respiratory failure that she was in at that time. I'm sorry. Her istat bicarbonate was very high, again, due to the respiratory failure state that she was in, and then her total carbon dioxide was also high. And then the C. diff testing was done on day 8 of the patient's stay, which did confirm the presence of C. diff, but then after the flagyl was added and her antibiotics were altered a little bit to specifically target the C. diff, by day 12, when she was intubated, the C. diff had resolved. Also, a D-dimer test was done. Her extremely high level there on day 12 was indicative of some increased fibrin and fibrin degrading production, which can build up because it is not filtered by the liver, as it should normally be with worsening liver function. So also the D-dimer can be high in the presence of edema or infection, so blood clot or clot formation or breakdown, which certainly she had infection and edema, and the likelihood of some clot, cell death and breakdown could have been occurring at that time. Her ammonia level on day 12 was also checked. Her mental capacity was, she was very confused just prior to being intubated, and so the likelihood there with the ammonia being high is that she had acute hepatic encephalopathy at that point due to her worsening liver function. The patient's nutrition-focused physical findings, her Braden score was a 20 out of 23 at admission, but decreased to a 12 out of 23 after her stay and increasing bacterial infections and worsening COPD and hepatitis C exacerbations. Her skin was pale and soft. She did have some scattered bruising. She had a lot of pokes and prods done throughout her stay. So her skin was a little bit compromised, but still intact other than the actual wound upon her leg. Her skin did get extremely, extremely tight with her increasing edema. With her edema, it was in her legs, arms, and in her abdominal region, ranged from 1+ to 4+ weeping throughout her stay. Her wound bed was on her lower left leg. There was black eschar and slough, and then also non-branchable redness surrounding the wound bed, which was very indicative of loss of blood flow within that region surrounding it, so some cell death around there as well. She did have some natural teeth. She did have several missing, and they were kind of sporadic across the front and the sides. She was asked if she had any chewing or swallowing difficulties, but she said that she had become accustomed to this for years and she could get her way around even pieces of meat. So she did not have any difficulties there. Her level of consciousness throughout her stay did diminish, eventually leading to her intubation. The patient's various care plans. Initially, her overweight obesity, because of her BMI of 42.4, was put in as a care plan. Decreased nutrient needs, caloric, and then also decreased sodium and protein requirements related to edema and poor liver function. So she had a couple of different decreased nutrient needs at that point. And then also inadequate energy intake because she had such poor oral intake, and then it did take a good bit of time to get up to even her goal rate. So inadequate enteral nutrition infusion as well, until we got to goal rate. The PET statement for this patient, her chief concern really is that she was malnourished after the period of time which she had been in there and had received no nutritional intake at all to help her state. So I wrote inadequate energy intake related to presence of bacterial infections and increased oxygen demands as evidenced by lethargic state, increased 2+ generalized edema, patient stated lack of appetite, and 22% average meal consumption for 12 recently reported meals. So in the intervention of this patient's care, I calculated her needs using the Mifflin St. George with a 1.2 activity factor because the patient was nearly bedridden. She could get up to go to the bathroom using a walker or a wheelchair, but otherwise she was not ambulatory at all. Her needs were calculated at 2,000 calories per day. Her protein, for anyone within our facility that has a sepsis diagnosis, we use 1.5 grams per kilogram of protein. And then for a BMI over 30, we convert to ideal body weight. So her ideal body weight was 120 pounds, so 54.5 kilograms. So using a 1.5, I calculated her needs at 82 grams per day. And then her fluid intake, we did 1 milliliter per calorie, so 2,000 mils per day. Her initial diet plan was a cardiac 2-gram sodium combo diet, and then her meal consumption was 57% of 22 meals that included 8 meal refusals in the previous 11 meals. So this was a little bit earlier on. When she was given that initial one, she was eating okay. At the very, very beginning, she was 100%, but then in the next couple of days, as her stay progressed, she got down to 57% there of her meal consumption. So monitoring really encompassed close monitorization of her dietary intake and then her continued meal refusals. Although she was at 57%, at that point in her stay, she did get down to 22% at the worst of her stay before she was put on the enteral nutrition formula. Ensure or Boost were offered to her, but she refused them. When asked if anything at all sounded good or if she would be willing to try anything new, she requested a cheese sandwich and some orange sherbet, which from nursing records were not consumed that day. An NG tube was placed over the weekend when the patient had to be transferred back down to the ICU. And an open system using Ensure Plus 8-ounce cans was administered at that point as a go-to for that patient. 20 mils per hour was the initial initiation, so it started very low within the first few hours of her being administered down there, which is recommended with the clinical care guidelines for the critically ill. So, and then she progressed to 40 mils an hour during that period of time with the Ensure. The enteral nutrition recommendations for during the period when she was on the Ensure Plus, in order to meet her daily needs, her full goals, she would need to have consumed 5 cans a day for an estimated 20 hours per day. So given a little bit of time to be off of it for various tests or procedures going on, or to bathe her. But she did progress to a goal rate of 65 milliliters per hour eventually, and then her flushes were also increased to ensure that she was getting enough fluid but not fluid overload. She was transferred to the ICU, and then her labs were evaluated, her residuals continually were monitored. Those ranged from 0 to 30 mils, which would be considered pretty acceptable tolerance for this patient. The condition of her skin also was evaluated. Braden scores constantly evaluated to see whether or not there was any improvement in wound healing. And then the presence of the diarrhea, which the diarrhea with the resolve of the C. diff did improve with time, and with the antibiotic use after the discovery of the C. diff. When the patient went into respiratory failure, she was mechanically ventilated. Her enteral nutrition formula at that point, due to her decreased oxygen capacity and her foremost chief complaint being her lack of the ability to breathe. We wanted to provide Oxepa, which at our facility is provided to all patients who are mechanically ventilated because of the inclusion of the lower carbohydrate load, but then also the omega-3 fatty acids as well, the fish oil, borage oil, which are shown to help in respiratory failure and any sort of respiratory distress. So using the Academy's guidelines as well for critically ill patients, we wanted to make sure that we provided at least 60% of the patient's estimated energy expenditure, but not 100%, which we had been previously at. We had been at goal rate with the 65 mils per hour with the Ensure formula. So we backed off on the formula and altered her needs using the Penn State equation for mechanically ventilated critically ill patients to provide, for the formula to provide 68% of her needs at a goal rate of 45 mils per hour in prevention of overfeeding. Because at that point the patient was pretty edematous as well. And then since we'd been at goal rate with the 65 with the Ensure formula, we immediately progressed to the goal rate of 45 an hour while in the ICU. This continued to be provided to the patient for a period of 4 days, and then after that time, the weaning protocols were put into place to extubate the patient, and she increased her cognitive function. She did at that point remain on her Ensure Plus tube feeding, which would also be a pretty smooth transition generally to a nursing home at that point, because it's a pretty general formula. It's not a specialized formula that would cost a whole lot more or be hard to access. So the patient remained on the Ensure Plus and then was transferred following her 14th day with us to a skilled long-term care facility. So just in summary, this is a complex case study patient with a lot of medical issues at play. These include end-stage COPD, cirrhosis, hepatitis C, cellulitis, pseudomonas, C. diff, sepsis, and respiratory failure eventually. Various meal refusals, numerous meal refusals, and the patient's malnutritive state really compounded her declining status. And the critically ill guidelines were employed both for the administration of the enteral nutrition at the admission to the ICU, almost immediately, and also with the provision to provide approximately 60% of the energy expenditure for the patient in the prevention of overfeeding. So those were important guidelines that were employed to ensure that we did not worsen the patient's mechanical ventilation dependency, and hopefully was able to get her off in a pretty time-wise manner after 4 days. And doing much better at that point. The long-term prognosis for this patient is really, it is poor but undetermined, really. The likelihood that she will develop some sort of reoccurrence of exacerbated states or bacterial infections if her wound were not to heal properly or not be taken care of properly does exist. So there are complications, but her long-term prognosis will really be determined by how well those complications are managed. And nutrition support, nutrition in general, is just one facet of a wide variety of disciplines that helped this patient and will continue to help this patient. So, but with the best efforts and the best research given, the best choices can be made at a fitting time for this patient. And we feel that that was done, and we hope that she does well in the future. And these are just the references cited for this presentation.